Ready to go? Okay. Good evening from Australia and most of Southeast Asia. It is very good morning, early morning in Minnesota, United States, for John, our speakers, and also late morning from Angus in London in United Kingdom. Good afternoon for most of Asia, Middle East and Indian subcontinent, and late afternoon in Japan and Korea. My name is Ted Ma, and I'm the inaugural president of the APOA, Hand Up Limb Society. This society was founded in the difficult time of COVID in May 2020, with foundation members from 15 countries across Asia-Pacific region. I welcome everyone who could join us for this webinar on masterclass in reverse shoulder arthroplasty. The APOA Hand Up Limb Society provides regular free education webinars to educate trainees and non-trainee registrars as well as consultants, surgeons who are interested in hand up limb surgery. Tonight, however, is a special webinar covering some important issues related to reverse shoulder replacement for the senior and perhaps less senior surgeons. I thank Stryker for sponsoring our webinars. I'm sure we all learned something new tonight from the invited speakers who are experts in reverse shoulder replacements. Apart from the biomechanics, you may be interested to hear the discussion, especially on biological supplementation versus metal augmentations to deal with abnormal glenoid morphology. I'd like to introduce and invite Professor In-Ho Jeong, who is the president-elect of APOA Hand Up Limb, to introduce Professor Angus Wallace, who would co-chair as moderator to start the session. In-Ho, over to you.
Okay, good afternoon, ladies and gentlemen. Thank you very much for your joining APOA Hand and Upper Limb Society webinar. And I would like to introduce Professor Angus Wallace from Nottingham, United Kingdom, as our moderator. Angus, would you please give any comments or hello to our members?
I'm delighted to be here for your conference. I just have a couple of slides, if I may share my screen with you. And I think, oh, I can't share because somebody else is sharing. So is it possible for me to share my screen?
Yes, sir, you can share now.
That's lovely. Well, I just wanted to clarify what a moderator is. I am a moderator with In-Ho Jeong, who is a very good colleague. According to the Oxford English Dictionary, a moderator is a person whose job is to help people or groups who disagree to reach an agreement.
Angus, we need your slides. Sorry about that.
Have you not got my slides?
No.
Oh, right. I thought I was sharing them. Hold on. Let me just go to... Right. Let me come back. I did try to share my screen. Ah, there we are. Share my screen. Thank you, In-Ho.
Okay. Now it works.
So, what is our modern? Your screen sharing.
Yeah.
Good. So, In-Ho and I are moderators, and the role of a moderator is to be a person whose job is to help people or groups who disagree to reach an agreement. So that's our role. If I was speaking to you with my Scottish hat on, the moderator of the Church of Scotland is responsible for keeping the senior members of the Church of Scotland and is in charge of them. So In-Ho and I will try to be in charge of the speakers and the audience at this conference. I'm delighted to be here, and I will hand back my screen now to Inho.
Okay, thanks very much for your comment, Angus. You always give us pleasure. Okay, before to avoid any delay, I would like to introduce our first speaker. We have 4 renowned speakers from all over the world. So Professor Joo-Han Oh as our first speaker. He was the past president of Korean Shoulder and Elbow Society, and he is an excellent clinician and scientist, publishing numerous papers in the major journals. So I would like to ask Professor Oh Joo-Han essential biomechanical concept in reverse shoulder arthroplasty so that we can start reverse shoulder. Okay, over to you, Professor Oh Joo-Han.
Thank you, Ino. Thank you, Ino, and thank you, Professor Wallace. I really love your tie with the Korean letters. So I really congratulate on your APOA Hand and Upper Limb Society webinar. I'm really happy to be invited as first speaker in terms of the biomechanics. I'd like to talk about today the essential biomechanics for successful reverse. I'd like to start with the humeral stem. As you know that the traditional concept of humeral neck shaft angle is usually at the beginning it was 155 due to stability of the construct. But according to several studies, including my papers as well, that the current trend is lowering the neck shaft angle, and we will talk about in offset session later. And also the traditional concept of the humeral retroversion in reverse is usually 0 or versus 20 or 30 degrees of retroversion, usually according to experts' opinion. But several biomechanical or the clinical study, including just published last year, that the individualized retroversion, according to the patient, is better, the superior clinical outcomes than fixed 20 degrees of retroversion. So I usually do the CT scan with including elbow, and I measure the patient's specific retroversion setting. My major talk of tonight is the offset of the implants. Sometimes we need anterior offset to give more the teres minor tensioning, or sometimes posterior offset in patient of the anterior bony deficiency and so on. But probably many of you have usually use the inferior offset to give more the acromial-humeral distance, more deltoid lengthening, or to prevent the scapular notching. According to my 2-center study with my friend JCU, that some kind of this inferiorization, that is the inferior notching, inferior offsets, is very important for prevent notching. It's probably the most important thing to prevent notching. So I routinely use this kind of the eccentric glenospheres to prevent scapular notching. But as you can guess, that this kind of the inferior offsets produce some kind of pain, even several millimeters, or cause the acromial fractures. Main issues recently is medial or lateral offsets. As you know that cuff tail arthropathies, usually humeral head goes superiorly or laterally. But first reverse, as you know that, give only distalization that cause the loosening of the glenoid components. So they made a little bit more medialized to give more deltoid fibers to recruit. And this probably is the basic concept of the reverse arthroplasty. But as you know, there are several problems of this kind of medial offsets. Number one, the loss of shoulder contour. Even they are really old lady, but they're really concerned about this kind of the loss of shoulder contour. And also this kind of the deltoid pull, distraction moment pull of the deltoid cause some kind of the instability or cause more adduction scapular notching or reduce the remaining cuff cause loss of weakness of the active external. Another thing we have to consider is the racial difference of the anatomy between the Asian versus Caucasians and so on. I have the direct comparison with Mark Frankel, that is the anatomy of the Korean and Caucasians in the United States, that as you can guess, the Koreans are small, but neck shaft angle was also similar to each other, but humeral retroversion is greater in Asian, and critical shoulder angle, that is, acromial length, is longer in Korean. So we have to think of the lateral offset reverse always for the small patients as well as Asian people. So how to solve this medialized center of rotations is 2A, glenosphere or humerus. Let's talk about the glenoid first. How to make the lateral glenosphere? Number one, thickness of glenosphere should be increased. Like this kind of the 2/3 of the sphere, that cause increase of the range of motion and reduce of the notching. But this kind of prosthetic lateralization cause the shearing force of the glenoid fixation, as you know, that it can cause the increase the failure rate. So when we can use this kind of the prosthetic lateralization, we just look at the scapular AP X-rays, and if measure the scapular neck length is more than 9 millimeters, it's a little worry about the notching. If it is less than 9 millimeters, I like to use this kind of prosthetic lateralization. Second way of the glenoid lateralization is bone graft. As you know, the 1 centimeter of bone graft cause make it long scapular neck. So I like to use this kind of bone graft in patient of bone deficient in the glenoid. This kind of 1 to 1.3 millimeters of the bone graft can be put on the native glenoid, and we can put more the lateralization of center of rotations. The last way of the lateral glenosphere is thickness, diameters of glenosphere, but it's this kind of the bigger glenosphere, 42, 46, probably this several biomechanical studies says that better range of motion and lesser chance of scapular notching with a better, larger glenosphere size. So we can use this bigger glenosphere if the patient is big enough. This kind of glenoid lateralization, we can improve the contour of shoulder and we can get more stability. And also we can decrease the scapular notching and improve fixed notation of the patients. However, as I said before, this cause of the glenoid lateralization cause some loosening, even though there are some cadaveric study and computer simulation study that there's no difference in 1 centimeters of glenoid lateralization in terms of the shearing force. And it is lucky that shoulder is not that the weight-bearing joint. Another disadvantage of the glenoid lateralization is deltoids, decrease of deltoid momentum. Probably this kind of the complication, disadvantage cannot overcome this pseudoparalysis or cause sometimes acromial fractures or severe pain. And the next way is to humeral offsets. There are this kind of lateral humeral offset, probably we can restore the cuff tensioning or increase deltoid wrapping by several ways. Number one, varus implant. Instead of the 155, we can put on the 135. This causes more lateral displacement of center of rotation. So several papers says that varus neck shaft angle reduce the notching and increase range of motions. So, but we don't know which neck shaft angle is the best. But as we said before, that current trend is lowering the neck shaft angle. Humeral stem positioning is also the way of lateral offsets. As you see here, right side onlay is much more neck cutting, or around 155, 135 is more anatomical inclination with the varus implant insertion. And we don't have to dig into the metaphysics with this kind of on-lay positioning. So we can preserve the tuberosity or the metaphyseal bone stock, and also cause better range of motion compared to other the innate system. Also, we can, if we can put the more thicker socket or thicker femoral tray, cause better range of motion. So by this femoral lateralization, we also improve shoulder contour, stability, and improve the scapular notching or active external, as well as glenoid fixation. But same complications, decrease the deltoid moment arm, and also sometimes overload deltoid cause acromial fracture. But this kind of the humeral lateralization also have various, not common, but a little bit serious complication with abduction notching, because close the lateral offset cause decrease the acromial and humeral distance, cause abduction notching. My patient x-rays post-operative, 3 months, 6 months, and 1 year. You can see here the abduction notching, acromial notching. So after 3 years after reverse, the humeral tray has broken. So this kind of complication we have to predict. So I reviewed my patients, more than 100 of the lateral offset implant that I measure several kinds of the measurement with pre and post-operative x-ray, said that according to my data that abduction notching was related to less distalization and more lateralization in lateral implant. So that is, if the patient has smaller preoperative acromial GT angle is smaller than 35, or humeral lateralization is more than 1.5 centimeters, probably high risk of the abduction notching. So in those kind of patients, we better use this kind of offset humeral tray to reduce the lateralization. So this kind of eccentric humeral offset probably cause a little bit more distalization and a little bit more medialization with lateral center of rotation. So my conclusion, with a better outcome with in terms of the biomechanical characteristics, medial or lateral, we can be selected according to patient individual needs. In patient pseudoparalysis or really fixed humeral head elevation, probably medialization is useful. But lateralization, we have to think when the patient has high risk of notching, such as scapular neck length is smaller than 9 millimeters, or subscap failure as well, and also loss of really weak active external rotation, we better think of lateralizations. Which way, glenoid or humerus? So at first, we better think about glenoid, scapular neck length, patient size, or bone defect of glenoid. And then we can choose the humeral component. According to the glenoid option, we can determine the humeral options accordingly. So ultimately, it is important to mix two concepts well to get the best result. So I will show my decision-making process of the how to decide of the offset. My routine is inferior offset around 3 millimeters. And then if the patient has pseudoparalysis or leg shaft angle is under 30 degrees, I like to use medial center of rotation. Otherwise, I like to use the lateral offset. If the patient is neck shaft angle is under 9 millimeters, really big patient, or bone defect more than 15 degrees, or central defect, I like to use the glenoid lateralization. Otherwise, I like to use humeral lateralization. But in case of critical shoulder angle is smaller than 32, and acromial GT angle is under 35 degrees, and humeral lateralization is more than 1.5, I like to use essential humeral tray with humeral lateralization. That is my decision making with the patient-specific decision. Thank you very much for your attention.
Thank you very much, Dr. Oh-Joo Han. It was an excellent lecture.
Thank you.
We have Dr. Ashay Kapre. as for designated commentator for this topic. I think some of our talk is overlapping with the implant design with the John Sperling later on, but Dr. Ashay, now over to you.
Yeah, thank you. Thanks a lot, Professor John. Thank you, Professor O. It was a very lucid presentation. You have very nicely explained regarding the evolution of the reverse biomechanics. Also, what are the design considerations that have evolved with the problems which are arising. So the talk has pretty much concluded, or rather combined, all the recent concepts as well as the problems we are dealing with. So from your talk, it is more of that the offset, I mean, glenoid offset should be individualized to the patient, as well as medialization as well as lateralization should be as per the patient's need. The biomechanical aspect, if you consider, there are certain questions we would like to ask. Which aspect, if you do a certain approach, right, the delta vector approach, which aspect of the deltoid do you consider more important in your decision making process while doing your surgery?
Yeah, that is really, really important questions. According to my last PowerPoint, that we have to think about what is most the patient wants. So if the patient is good deltoid and patient is pseudoparalytic for several months, I think the shoulder elevation is most important part of the surgery. So in those cases, even the patient has we better to get the shoulder elevation. So distalization with some medialization is important. If the patient has no active ER in those patients, we can use the LD transfer with the reverse and so on. So in those cases, we have to focus on distalization and medialization. But some patients, some pseudoparalytic patient has the good elevations with really severe pain and so on. So in those cases, we better think more on lateral offset. In those cases, we can put on lateral implant, kind of the humeral lateralization. Glenoid is okay. We can use just humerals with lateralization. That is enough. But in case of some patient has the high risk of the, the neck shafting is really short scapular neck, we better put more on bigger, the thick glenosphere cause. So we can choose according to the patient's the anatomy and patient's symptoms and so
on. Another question is that.
Johan, we've had a question come in, if I may. Can I interrupt you for a minute?
Yes, sir.
One question, which is more relevant, clinically, anterior or posterior offset in terms of arthroplasty? Now, I have already partly answered. All humeral heads are posteriorly offset with a variation of about 5 degrees to 35 degrees retroversion.
Correct.
In my own practice, I tend to put reverse shoulders in 20 degrees retroversion. What do you do?
Yes, I mean the anterior and posterior offset is, we don't have to think about much in routine reverse, I think that. But after head cuts, we usually make the point of the owling, that is for the humeral stem. If it is a little bit eccentric, I'm consider sometimes anterior and posterior offset. And after the trier the humeral stem, if it is too anteriorly placed, sometimes we need a little bit posterior offset to give more the bone stock on the anterior side and so on. That's not routine, but sometimes it is necessary, I think.
That's perfect, actually. What you are doing is to use the bone that is available and use it in the most practical and sensible way. And you can see that once your head has been removed. Now, I'm going to hand back to Ashay I apologize for interrupting, Ashley, but our job is to pick up the questions and deal with them. Over to you.
Professor, I mean, it is, yes, thanks a lot. Oh, I was coming to that. I mean, to add Professor Angus Wallace's question, I would like to ask you, you have mentioned regarding to prevent scapular notching, you have a particular measurement, like you add 1 to 1.5 centimeters of bone graft. So is the thickness of this graft also individualized? How do you plan for it?
Usually that's for the bone grafts bio, usually 1 centimeters of thickness is correlated with 1.5, 1.2 centimeters usually. So eccentric bone wear of the glenoid side anteriorly or posteriorly, I don't like to eccentric rimming because it causes some part of the medialization. So I don't like the eccentric rimming. Instead of it, I like to use the bone graft. So my rule of thumb is the 15 degree is usually around 1 centimeter. So I put on there with a bone graft and fix it with the peripheral screws and so on.
That's it. I mean, is there any other questions, Professor?
Okay. Ashay, let me interrupt you again. We have one question from the audience. I think this directs to Professor Juhan Oh's study.
Yeah.
You understand that we have lots of radiographic measurement and indices. Mm-hmm. So all different combination of humeral stem and glenosphere, does it really affect range of motion? Because all numerous factors are all interconnected. So his question is like this. I understand the neck cut is at 135 degrees, but the angle of the edge of the liner creates a higher angle, and in some cases 255 degrees. Is this taken into consideration in the studies you quote?
Yes, really, that's really clever questions. Yes, most of the implant has usually, even though they have 135 neck cuts, they have the tray angle. That's usually the neck shaft angle, rear neck shaft angle is around 142 to 147. So around 145 is most common, I think. Yes, I'm considering that the angle in my test. So recently, most of the implant in the market, they are plus or minus around 145, I think.
So we have one more question from the audience. It was quoted that subscap dysfunction leads to failure. Weaker rotated cuff is itself a contraindication to reverse shoulder. So how would you like to answer this question?
I don't think so. Even the patient has full the subscap failure to repair, I like to use reverse arthroplasty, but in case of we cannot repair the subscap after the implantation, a little bit higher risk of the subluxation. So I like to use a little bit lateral implant instead of the medial one. And also the lateral implant give more tensioning of the subscap or the remaining inferior teres minor that cause more stabilization. So I like to use the lateral implant in those kind of weak rotated cuff patients.
Excellent. Angus?
Yeah. Angus?
One question. Okay.
Johan, I recognize that the bio implant, somebody's got a lot of sound. The bio implant has been developed by Pascal Boileau in order to lateralize the glenoid. Do you know, or have you worked out whether there is a difference in the need for that comparing one prosthesis with another? In other words, does the design of prosthesis dictate whether you need to use a biological offset.
So you mean the indication of bio, you said?
Yeah.
Yeah, I'm not sure that Pascal still used routinely for the bio for all implants, but probably sometimes it's useful in short scapula neck. That is the scapula neck length is under 9 millimeters, a little bit higher risk of notching. We can put on bone graft over there to make long the scapula neck. Or as I said before, some kind of the glenoid wear, posterior wear or the superior wear. I like to use bone graft because in Korea, we have little company to use the augment base plate. Probably John will talk about that. That's if you can use the augment the base plate, you can use it, but I prefer to use in practical the situation in Korea, I like to use the bone graft for those kind of the bone deficients, even in 5 degrees or 10 degrees. I don't like essential rimming, but put the bio on that.
Of course, some of the reason for using a biological implant is that the modified glenoid base plates are more expensive. And as a Scotsman, with my Scottish hat on, the money is very important, the financial cost of the operation.
Yeah, right.
Over to you, Inho.
Okay, Ashay, you have some questions.
Yeah, there are lots of questions in the question box. One question is pertinent, sir, Professor O. The audience would like you to answer regarding the role of inclination and how it influences the biomechanics of reverse. Inclination of the glenosphere.
I mean that. Inferior. Okay. Yeah, there's a lot of debates of the inferior inclination, 10 to 15 degrees. I don't agree. We have to do 10 to 15 degrees of inferior tilting, but we have to consider the inferior tilting. Otherwise, the surgeons forget about the superior tilting of glenosphere. Usually, normal anatomy of glenoid is 3 to 5 degrees of superior tilting. Otherwise, we give intentionally a little bit 10 degrees inferior tilt. Probably it causes superior tilting of glenosphere. So I know that John usually routinely use 5 to 10 degrees of glenoid augment to prevent those kind of complications. So 10 degree is not that important, but you have to think about normal anatomy of glenoid, that is 3 to 5 degrees of superior tilt. Superior tilting, that is the dangerous.
Okay,
thank you.
I would like to excuse those participants who uploaded lots of questions. I'm intentionally preserving some of these questions for the third session because it can be very interesting if we can have a debate at the last minute. So those of you who asked the questions, please bear us a few more minutes. So,
I will write down on that, okay? I will write down on that after my talk, okay?
We'll appreciate it.
Thank you.
Angus, over to you.
Thank you very much. Juhan, that was a fantastic presentation, and thank you for keeping it at a level that people can understand. That was really appreciated. And it's my responsibility, my honor now to introduce Ashish Bubakar, who is head of the Department of Shoulder and Sports Medicine at Dinanath Mankenshkar Hospital, Pune, India. Ash, did I get that right?
You're almost there.
Almost there. He's founder president of the Shoulder and Elbow Society in India. And not only is he famous in India as a shoulder surgeon, he's also famous in the UK and is known very well in the UK and is a good friend of our British Elbow and Shoulder Society. So I'm delighted that Ash has agreed to talk to us and present to us on reverse shoulders. Ash, over to you.
Thank you, Angus, for that very kind introduction. And it's always good to share thoughts with people from Queen's, Nottingham, and we're inspired on the shoulder program with your rehab and work at Nottingham. Thank you very much for this invitation. And Tedma, and it's a real privilege that you put this superb webinar together. So without delay, there's so much to cover in this talk, and my remit is to speak on exposure and techniques and complicated cases. I'll move on. So divide the talk between the tips and tricks on approaches and a little bit on techniques, and then finally finish off on how we go about complex cases as such. So I think it's a given that all of us would resort to a beach chair position. It has a lazy beach chair, deck chair position. It's important to stabilize the cervical spine. I spend a lot of time doing that. And there's a lateral tilt added. I'll talk about that later when we come to the glenoid exposure. It's very important that the arm must be completely free so that you can bring it back in extension when you want to ream the humerus. And so the table should not be a constraint to exposing the proximal humerus. And I almost always use the Mayo table as my first trusted assistant. Now, I've always carried the torch for the deltoid split approach because I was trained by the French, and they would do all their cases even today by the deltoid split. There's a time I was under the impression that McKenzie approach or the deltoid split approach was the complete answer to global warming. And then slowly I understood, and as you got experience, that there are other approaches as well. So now I'm fairly equipoised between deltoid split and the deltopectoral approach, but you must know which to do when. Most of us are sold out on one approach, but I would mix and match on these. So certainly when I have a simple cuff tear arthropathy without steep proximal migration, I would head to deltoid split. It's still my favorite approach. Is much quicker, shorter, and very elegant with a smaller scar. And especially if my subscapes are intact, then I would rather not touch it by doing the deltoid split. But it's not extensile. I cannot use it for complex revision cases. And certainly if it's a trauma case, 4-part fracture, I'm going to rely on the deltopectoral approach. When one finishes the deltoid split, it's very important to do a proper, diligent, transosseous deltoid, anterior deltoid repair through the acromion with a non-absorbable number 2 suture. Certainly don't use it for cases like this where there's a steep proximal migration, because you would compromise the exposure and then result in a difficult case. The deltopec is, of course, the go-to approach. Most of us are familiar. And if you're familiar with this, then go ahead and do your deltopectoral approach. My only thing is that my incision is fairly lateral so that I'm heading into the glenoid, and plus it takes my scar away from the axilla, which is what we want to do. It is not only modular, it's an extensile approach. So when you're in trouble, you can extend it proximally, distally, easily. It's supposed to preserve the deltoid, but it's not so. Your retractor on the lateral side is very critical. If you see some of your proximal humerus fracture cases or the deltopectoral cases, 6 months down the line, they're sloughing off of the anterior deltoid. And that's probably because the anterior branch of the axillary nerve has been damaged because of that anterior bone lever. So you must be very careful where you put your Hohmann in. It's not necessary that the deltoid is always protected. I would use this for all my revisions. And if you're planning a lat dorsi transfer at the same time, then I'm compelled to use the deltopectoral approach. So there are a number of implants available, and so to each his own. Those of us who are loyal to one single implant, then they know which approach to use and they can stick to that. But those of us like me who flirt between different prostheses, then you must understand a caveat that not all prostheses have a different resection guide for deltopectoral and deltoid split. So it's important that if you're using deltoid split and deltopectoral, there are separate resection guides for individual prostheses. Not all prostheses are designed to be inserted through the deltoid split. Coming to instruments, I'm sure most of us share the same instruments, but I would find it very difficult to do a reverse without a pair of Gelpi. A blunt Homan, not the standard sharp Homan. I need a blunt Homan, and I'll show you why. And of course, the wire retractor, or you can call it the Playboy retractor, is critical to expose the glenoid. When I come to the glenoid exposure, I would roll the table 10 degrees away from the surgeon towards the anesthetist to bring that glenoid into view. And when you do an adequate humeral cut, then your exposure of the glenoid is absolutely capacious, and you will have a very good view without compromising reaming and exposure. But be careful when you're doing a very conservative humeral cut, is going to come in the way. The wire retractor has to be put in very safely in a under observation, so that you're not damaging the axillary nerve and putting it right under the 6 o'clock position of the glenoid. Do I resect the triceps always? I don't, unless I'm finding a very tight, difficult revision case and I'm not balancing the soft tissues enough. I would resect the triceps, but I wouldn't do that in all my cases. So here you see the deltopectoral approach, and this is the blunt Homan that comes in. The reason it's blunt, it's a very broad tip, so it's not damaging the posterior cuff, and I can freely tension it, and that really opens up the book and allows the proximal humerus to herniate out of the wound, so you get a fantastic exposure. So what you see in the back is a very broad blunt Homan, and here you have a standard sharp Homan which goes underneath the neck of the humerus. Excuse me. So on the humeral side, the subscap can be taken down in a number of different techniques, and you can use whatever floats your boat, because this is an elegant paper from George et al.'s team, 2012, I think, where they did a randomized study between a lesser tuberosity osteotomy, a tenotomy, and a sleeve, and there was very little to choose between the three. They had all similar results. On my principles, for my total shoulder replacements, anatomicals, I would always do a lesser tuberosity osteotomy. And for my reverses, I do a flake or a sleeve subscap resection. And I think the humeral side releases are underutilized always. So when you're doing that inferior capsule release, rather than risking the axial nerve under the glenoid, I would spend some time doing the release on the 6 o'clock of the humerus position. You can do it extensively without any restrictions. Your humeral resection cut is going to dictate the glenoid exposure. So be firmly sure, and I base that on my pre-op planning. So it's not a fixed cut for every patient. I have no shame in saying that I use the C-arm imaging very frequently during my surgeries, unless it's a very straightforward, simple case. And this is a 4-part fracture case. And if you look at the top diagram here, you can see the lesser tuberosity and greater tuberosity are floating up here, even on the axials. And then when I pass my sutures and do an elegant repair, I know that they're sitting there anatomically. So I need that confirmation so that 2 months down the line, your X-ray looks like this, where that greater tuberosity is back in position as if it belongs there. The lesser is also wedded to its anatomical base. It's important to notify this on the axial X-ray also. There's a nice paper from San Diego where they have shown that it's not uncommon for the lesser tuberosity to float away, and it's not guaranteed that it will heal back into its own bed. So cases like this one on the left, you have a proximal humerus, poorly fixed fracture, subluxed axial nerve palsy. These are difficult patients, requires a lot of application, lots of releases. On the right, you have a 68-year-old lady who has had a cuff repair and Lataji that's gone wrong. And then these are revision cases, a lot of scarring, the soft tissue is not clear. So you will need to do a lot of releases, but you have to be very careful of the brachial plexus. So on a deltopectoral approach here, on the left shoulder, I'm bringing in my wire retractor here, tuck it underneath the glenoid. And when you pull it down, it's not only exposing glenoid, it's taking the shaft of the humerus away. That's very important, which has a stem inside it. And then I come in with a sharp Homan at 10 o'clock, and then another Homan at 2 o'clock. So this is my standard positioning of my bone levers at 6 o'clock, 2 o'clock, and 10 o'clock, and this will open up the window completely. I leave that stump of long head of biceps as an anchor. It's like my lighthouse. It allows me to grab it with a marten, and then I take down the bovie so that I can take down the anterior labrum through the MGHL and IGHL, and then I leave that stump there down in the axillary pouch, and then move in and use the martens to grab the remaining part of the posterior labrum, and then grab it with the marten and finish off. But I try and keep that ring together. So when I've removed the labrum, I've removed it as an entire 360-degree limb as far as possible, so that I have practically done all my releases, and that long head of bicep stump helps me identify where I need to start. So that kind of clearly exposes the entire glenoid so that I'm good to go for the next step. Now you must understand that there's always a major conflict between the sharp powered reamer and the retractors here. So this is the Y retractor. Sorry, let me go back there. Okay. So this is the Y retractor that goes in gently underneath at 6 o'clock. Sometimes I add that on the posterior side as well because of the curvature. It allows the reamer to come in. It's not unusual to have the reamer conflict with the retractor. And in that case, it is dangerous because it can fracture the glenoid. One doesn't understand the power of these reamers. So sometimes you have to be very careful and ensure that it's freely rotating and it's not catching on any of the reamers. That can be dangerous because you're dealing with some very fragile bones, very osteoporotic ladies in these cases. So as long as you have free run, and then you have to do only a gentle reaming. I don't do an extensive reaming like the acetabulum is barely just a dusting of the glenoid. But here's my take on those frail old grannies. I avoid the reamer and I use a curette because I'm just doing this safely, but you need to do it in a uniform manner. I picked this idea from Mike Roblowski from Wrightington when I trained under him for hip arthroplasty. And I use this very regularly for those frail ladies who have a very poor quality bone. It's a safe technique to use rather than those powerful reamers when you suspect. So do you always need to do a trial reduction? I would say yes. So I have seen senior surgeons getting embarrassed because they put in the prosthesis and they couldn't reduce it. So it's risky. But once you get experience, then you can put in a prosthesis directly. But on the top video here, you see I'm struggling with that trial reduction. So it's too tight. And so I'm going to remove the proximal trial prosthesis and then go ahead and do some more releases. So what kind of releases do I do? So you best to do a humeral release on the medial side, and that's safer. If still that doesn't work, then go on the glenoid side at 6 o'clock, release some of the anterior inferior tissues between the 5 o'clock and 6 o'clock position. And if still tight, then you go back and then perform a humeral recut, and that's about 2 to 5 mm, and that should be enough. You don't want to do too much. And it's always better to do a conservative humeral resection and then augment it with another 5 mm cut as such. What is important to recognize is the upper third rule, that if your glenosphere is very close to the tibial tray and your tibial tray is at the upper third of the glenosphere, then you know that this reduction is going to work. Then you need not do a trial reduction. If the humeral tray is too high up on the glenosphere, you should be careful that this is not working. Ensure that the anesthetist, the muscle relaxant has not worn off, because I've been caught out a couple of times that way. To be honest, I'm going to speak for all of us here. This is the most fiddly, embarrassing step. It is difficult. So you need to get used to process. As your glenosphere goes in, do remove that Y retractor, because that prevents the glenosphere from going into its home position. And then gently remove your holder and then bring in the punch and knock in the glenosphere. Prosthesis of the glenosphere prosthesis who have a cannulated hole will not accept the screw unless it is in its home position. So that's a good thing for those prostheses. But this is a Biomet comprehensive and it doesn't have a cannulated hole. So you don't want to fix it in eccentrically. So be sure that you have a good exposure. You've removed the Y retractor. And once it's home position, then you just need 3 knocks with the punch and then it'll go in here. It requires a little bit of practice. A good exposure will allow an easy insertion. Even in the most experienced hands, this can be a very fiddly step because it's difficult to grab hold of that smooth glenosphere. You must remember stiff shoulders, revision cases, malunited fractures, and certainly the persistent dislocations are very difficult cases, and they are going to be challenging. So you need to spend time, larger incisions, good releases, patient, don't rush it in here. Cases like this, where there's a very medialized glenoid vault, old hemiarthroplasties, are going to be difficult, and they're going to be much more tighter. So don't take them lightly. Be sure you're downsizing your glenospheres and the humors. Now you could split the shoulder community into two groups, those who repair and those who don't repair. There are several subscap agnostics who never ever repair the subscap. Again, I'm equipoised and I decide on a case-to-case basis. If I can easily repair the subscap without tension, keeping the arm in 45 to 60 degrees external rotation, I would without hesitation repair the subscap. It's a good stabilizer there. But subscap is important that it's a schizophrenic muscle, and many surgeons believe that in abduction, the subscap can pull down the head and prevent abduction. And that's the premise why many surgeons do not repair the subscap. There's a nice paper from Jason Clark, 2012, JCS, where they said it doesn't make a damn difference because in their study, they had equal number of complications in their both groups. But if your deltoid is poor, if your medialized prosthesis, I would recommend always repair the subscap. So finally, coming to a few complex cases, this is a young lady.
You've come to the end of your time. Can you wind up, please?
I will wind up very quickly. So this is a 45-year-old lady, everything gone wrong, 2 surgeries by surgeon. We're compelled to do a reverse in a young lady, and you can see that she's done reasonably well, but it's a shame that we had to do a reverse shoulder for a 45-year-old lady. This is another patient. This is a neglected posterior dislocation. Surgeon didn't pick it up, and this is what has happened. The head of humerus is behind the glenoid, and this is his result. We've had to do, again, a 51-year-old, but this is the lasting solution for him. But these are difficult cases, and because they're revisions, they're going to be highly common. Finally, I'd just like to finish off with this, where when you're doing a revision for a hemiarthroplasty, it's very difficult. This process is not going to come up. You must know the Van Thiel osteotomy, and this was described very nicely by George et al. Where you keep the pec major island graft, which will provide blood supply to this long linear osteotomized fragment. You don't want that to get infected or necrotic. So in conclusion, I would like to say your pre-op planning is most important. You should have complete set of instruments. I think the DeltaPEC is a go-to approach for all of you when you're initiating into reverse. It's the complicated revision cases, fracture cases, which are risky. You need to be very careful on that exposure. I haven't discussed the subscap repair or notching for time issues, but results can be enduring. Thank you very much for your patient listening. Thank you.
Thank you very much, Ash. We now have a commentator, is Ahmed Fahad Asir.
Yeah. Yes.
Lovely.
Yes, thank you.
I'm going to hand over to you, Ahmed.
Yeah, thank you very much. Thank you, Dr. Ashish, for your presentation, nice presentation. Actually, you are using the Mayo table all the time, and we used spider in the cases. It will make your life easier, even in the difficult cases. So you will be, I advise to use it sometime if it is available with you. The second thing, one of the most important thing that minimal humeral cut, because a lot of people, they are taking too much from the humeral cut, and they will struggle later on, and they will put a lot of augment that's just to balance the soft tissue and the offset. The third thing that actually we are using nowadays, the 3D printing for this. So we are taking this picture from the CT, and we are putting this the fracture type and the glenoid. So we can just check the direction and the length of the screw pre-operatively, and we can just use the we know when we expose there, we can find exactly the direction of the screw all screw in the glenoid. Yeah, with this 3D printing for patient by patient. And
okay, Dr.
yeah.
Ahmed
Can
Asur.
we just check with Ashish? Ash, do you use any 3D printing at all in your practice?
So, Angus, like the Scottish, we are a very price-conscious country as well. So, seriously, we have only 20% of our patients are insurance. But if I'm dealing with a complex case, a revision case, then I would use 3D printing. We also use the HoloLens to have 3D holographic imaging intra-op. But for my standard primary reverses, I don't use these.
Ahmed, back to you. Have you other points?
Yeah, there is regarding the withdrawal of the muscle relaxant intraoperative, because we are receiving the patient fully relaxed and we are putting this instrument and the implant. Then post-operatively, if we are missing, he has very good muscle relaxant, post-operatively you will find that the soft tissue will be tight and there is restriction of movement. So I am using sometime that I am telling the anesthetist to minimize the muscle relaxant after I put my in the sizing. Then I will proceed later on, and I find the difference. Yeah.
Yes, Ahmed, I think that's a very good point. But you
Yeah.
must be a lucky man, because my anesthetist sits in the coffee room. And so my problem is that when we start off, the patient is much relaxed. It's only 2 or 3 cases that I noticed that as the patient has worn off the muscle relaxant, suddenly the trial was easy and then the final process was difficult. So if you realize there's a mismatch between your trial reduction and your final reduction, don't panic. It's probably because the muscle relaxant has worn off, because some patients metabolize their muscle relaxant differently. So
Yeah.
sometimes junior surgeons would panic as such.
Okay, Ahmed, may I interrupt you in a minute?
Yes.
I think it's a very important issue we should explain in this session. In a very tough shoulder case, complicated case, how can we expose a difficult glenoid? Probably John may have some comments on that. How you deal with the difficult glenoid exposure? Any of your surgical tips?
Yeah, I think we'll have time for discussion. I think for me, the key for glenoid exposure is actually on the humeral side. So for me, the 4 keys of glenoid exposure: aggressive head cut, osteophyte removal, deltoid mobilization, and inferior capsular release. So if I'm having a hard time seeing the glenoid, I typically go back to those 4 steps, and I think that can get you there.
Another way to do that is to do a clavicular osteotomy approach.
Oh, that's what I saved for Angus.
Absolutely.
I was trying to stay quiet.
So yeah,
yes, I developed the clavicular osteotomy approach way back in the 1980s, and it is a good approach for a very complicated situation, but it's not necessary for standard surgery.
Yeah, it's still alive in Korea, if I can say. So we have some comment from Yap. Okay.
Yeah. Well, in the approach, the deltoid split approach, I find it very helpful, not only to take off the inferior capsule under the glenoid, but also take off all the capsule from the humeral side. Then the capsule is just hanging like a hammock, and it makes it easier for a retractor to go underneath the glenoid. So on both sides, do an extensive capsular release from the bone.
Oh, Dr. Yap, in that case, do you see any clinical difference between 2 approaches, deltopectoral and deltoid split?
Well, both are actually the same. If you do deltopectoral approach, and I use mainly the deltopectoral approach for revision cases, when failed fracture cases or failed hemis. So you have to go deltopectoral, and that is normally very difficult. It's always stiff. There's a lot of adhesions around the shoulder. But for the glenoid exposure and the humeral exposure, to take off the capsule at both sides and even cut the capsule in the length, taking care of the axillary nerve too. and even excise the capsule completely inferiorly if needed. And that will give absolutely good release in these difficult cases.
Yes, Ashish.
I think that was a very important point that you made. Is there a difference between the deltoid split and the deltopectoral? In accomplished hands like the panel here, I don't think it's going to make a damn difference. But in the revisions that we have done, when we've noticed that a novice surgeon has operated, I think the common error with a split deltoid approach has been a tendency, if you do it in difficult patients, to keep the glenosphere superiorly inclined. And that has been the mode of failure. And on the deltopectoral side, because of inadequate exposure, the glenosphere tends to be antiverted. These are common errors done by novice surgeons. So we must work on that so that if you know and anticipate this, then you would correct these errors.
Ash, I just want you to educate some of the audience. We've got some registrars in the audience. They heard you refer to the Playboy retractor. Can you just describe why it's called the Playboy retractor? It's the two bunny ears, isn't it?
Yes. Angus, I
I'm
hope
just
you're not
helping
wearing
you.
the... Thank you very much. I hope you're not wearing the kilt. Very naughty. Yes, I thought I would grab some eyeballs there by saying that Playboy retractor, but I think it's my best. It's a workhorse for exposing the glenoid. Yeah.
Well, the reason I raised it is I think it's a super instrument. And I think it makes life so much easier, both being used inferiorly in order to hold the hard tissues and soft tissues down. But I saw you using it quite a lot posteriorly,
yes,
and it works very well in the
yes,
posterior position as well. So it's a lovely instrument. And if I can go back to Ahmed,
Yes.
the Spider is a great tool. But it
Yeah.
was banned in our hospital because it was so heavy that health and safety said it was unsafe to use it. Now, it may be lighter now than it was when it was first developed,
Yeah.
but it is quite a heavy tool.
Yeah, now Smith and Nephew, they have something with a battery. It's very nice. So I am
Okay.
using this all, yeah.
Okay. That's lovely.
Yeah.
We have a few more minutes, but we have a question from the participants regarding the patient-specific targeting device. I think John Spalding has some comment on that. What do you think?
I think there's an opportunity. I think we've moved from plain X-rays to CTs now to 3D planning. And I have to tell you, I've become more and more impressed with the ability for guides in a reproducible manner to ensure that the glenoid position is accurate. I actually think the guides are very helpful in the planning on the glenoid side. I don't think they're as helpful to plan on the humeral side because of the issues related to soft tissue tension. But I think it has the opportunity to decrease the outliers, particularly in folks that are lower volumes. I think, it's interesting. I think Richard Page may have a comment on this because I saw some preliminary data from the Australian registry that showed that the rate of failure is lower with guides. Is that correct, Richard?
Yeah, thanks, John. Yes, that's the early evidence. We've not done a sub-analysis of that yet, so it's coming along. But we know that in the knee, for example, registry data has shown that as well. So it sort of falls into line. It's as you suggested, it brings the outliers to the centre. And whether it's the guide itself, John, or it's the planning process that goes with it, that's a bit hard to separate out at the moment. But it's all part of the whole package, obviously. Yeah, sorry. And I was just going to make another quick comment, if I may. There was a question earlier in the first talk just about the most common mode of failure of reverses, and certainly our registry data and as our experience is it's instability, particularly in the first 3 months and particularly in males. So getting that right and all the factors around alignment and positioning right, which is a segue, John, into your talk. But I think that is really, if we're going to be teaching sort of basic principles, that's where we really need to focus on. There's a lot of interesting stuff happening out there with customization, etc. But getting it right the first time and positioning is crucial. That was all. Thanks.
I can come back to Ash. There are a couple of things, Ash. Firstly, you emphasize the importance of repositioning the tuberosities, even in a reverse shoulder. Now, I was delighted that you made comment about that, because I think it's actually very important. I think there is a tendency for people to believe they can put in a reverse shoulder for a bad fracture case and assume it'll all go well if you don't worry about the bones. I think it's actually quite important to try to reconstruct the tuberosities. What is your view about that?
Absolutely. You're mirroring my thoughts. And although we consider the reverse to work in cuff deficient shoulders, that's not the case in trauma. So not only does healing the tuberosities add stability to the patient, but it provides external rotation, which is a very important part of restoration of function and a good tuberosity healing. In fact, published literature shows that the tuberosities are more likely to heal in a reverse rather than a hemi-arthroplasty.
And I have a question from Stuart Proper. May I ask, he says, how many assistants each of you get to have? And Richard Page would like to answer that, but Ash, I think you should answer first from India and then Richard from Australia.
Right. As I said, because
you've got lots of people in India. You can
yes, actually. So 3 for every spider. So we do have a lot of fellows as well, and it's important to bring them in for every case. So we usually have at least 2 assistants, if not 3, during surgeries, because it's nice to be participative and part of that. And they keep picking my brains as well at the same time. So that's one of the reasons we don't use a spider here.
Well, you are lucky, and certainly in the UK, we started to have a big reduction in our assistants about 7 or 8 years ago, and it made quite a big difference to the difficulty of surgery.
Yes.
Richard.
Yes.
Yeah, thanks, Angus. I do use a positioner, but I get 2 assistants. And I have to say, I know some of our Scandinavian colleagues don't have any. And I have to say, I admire that. They are obviously very dexterous, because I would struggle. I really need, you know, I think unless you use a ring retractor that holds all your retractors for you, you need hands on deck. And certainly I do. I'd have to think really hard not to have 2 assistants.
So Richard, that's 2 assistants plus 3. A spider equals 3.
Yeah. Like I said, some of us need all the help we can get, Ashish.
And Ashish, I've been asked by Sofan Warnasuda whether you always use bone cement.
Right. I try my best not to use cement. I much prefer an uncemented prosthesis, and that works best. Saves me a lot of time. And the modern uncemented prostheses are very good, reliable. The only time I might need cement, and I'm not against using cement, is in trauma and in revision cases.
Fine. Ahmed, you've got the last speech. Have you anything you want to say?
Still, it's not clear. I have a lot of questions that you are using the reverse shoulder in cases that you have rotator cuff arthropathy, and the rotator cuff will be in the GT. Why should you put the GT anatomically, and why the GT will be one of the most common cause of failure of the GT non-union, although you are not depending on the GT, you are depending only on the deltoid.
Okay, you're asking about the greater tuberosity. I'm going to hold that for the discussion later on, because it's not a straightforward answer. So if we can save it up and we'll move on, I'm going to hand over. After I've thanked Ash. Ash, that was a lovely presentation, and the pictures that you brought us from the operating theatre were really appreciated. Yes. Thanks very much indeed. Over to Inho.
Thank you.
Thank you, Angus. Thank you, Ashish. Now we have our star speaker today. Now I'm happy to introduce John Sperling and special commentator Richard Page from Australia, and they will update us about implant design, current trend, and technology in reverse shoulder arthroplasty. John, please.
Perfect. Well, thank you so much again for the opportunity to participate today. And what we're going to be talking about today is some of the new technology that we're having in shoulder arthroplasty. I really enjoyed the talk so far. Very interesting hearing about the difference of opinion, and I'll share some of those differences of opinion with you as well today. So my disclosure, we know that in reverse shoulder arthroplasty, it's essential to avoid superior tilt, to avoid component loosening as well as notching. The other aspect we've learned, it's important not only to be able to have that avoidance of superior tilt, but inferior placement is very important. If you place the base plate too high, you also place yourself at increased risk for component failure. And I think one of the things we've learned now is that when we do an anatomic total shoulder, the glenoid occupies the entire glenoid. But when we do a reverse shoulder, the lower part of the glenoid is where we place the component to prevent impingement. And I think we need to think about the inclination separately. And this is the paper by Pascal Boileau in April 2019 that I think really helps change our thinking on this. So we know from the central part of the glenoid, there's 10 degrees of superior tilt. But when you actually go to the bottom part of the glenoid where we place the base plate, 20 degrees of superior inclination. And as Professor O noted, we have to correct this in all our reverse cases. So even in the absence of glenoid wear, correction of the RSA angle 20 degrees is required to create a neutral base plate position. And many of us prefer 5 to 10 degrees of inferior tilt. Now you're talking 25 to 30 degrees of correction, which is a lot of correction we have to do on our reverses. And essentially what it comes down to is there's really only 3 ways to correct this RSA angle. You can eccentrically ream the central and inferior glenoid, which we'll talk about removes quite a bit of bone. You can bone graft that. And as we're starting to see in the literature now, the rates of bone graft failure with reverse are starting to become recognized. And the other option is an augmented base plate. So what are the problems with eccentric reaming? Well, I think what we've learned is that we remove a large volume of native bone. And unfortunately, we remove the best quality bone. So in a fracture circumstance, we tend to remove that hard cortical bone. And in an elderly patient, what we're left is with soft cancellous bone. And then we medialize the base plate, which has a number of negative aspects, as we've heard a little bit about, with a negative impact on the soft tissue, shorter screw fixation, and again, as Professor O noted, increased risk of impingement. So eccentric reaming can be problematic. And this is an interesting study. It's an old study, but really shows that if you do 1 millimeter more of incremental reaming, you have a 43% decrease in contact of the base plate with cortical bone. So the glenoid bone is very precious and the cortical bone is very precious. And we need to be able to preserve that. How about bio-RSA? This is interesting. I think some of the challenges with this, it can be complex. You can crush the bone during the procedure, fragmentation, as well as non-union. And it can be technically challenging. If you place a graft that's slightly too prominent, the base plate will not seat on native bone. And if the graft is too thin, you get no contact with the underlying base plate. And this is an interesting study. This was done by Brad Edwards, who spent a year trained with Pascal Boileau and on the bio-RSA technique. This was presented at the Academy, prospective study of bio-RSA versus standard RSA. I think the things that you see with this that are starting to be recognized is high rates of notching, 78, 70%. And bio-RSA did not help when it came to notching. And I think this is the other thing. In Brad's hands, an expert surgeon, over 1/3 of the cases had some graft resorption. And there's 2 very interesting papers that have come out. So the Rothman Institute in Philadelphia with Jerry Williams, Joe Aboud, very experienced surgeons, on a primary reverse with bone graft, 25% failure rate. And we have a paper from the Mayo Clinic looking at bone grafting with revisions, 25% failure rate with a variety of implants and a variety of surgeons. So I think our hip and knee colleagues would say We figured this out years ago. Bone graft is not a great idea. You should think about metal. So how much bone can you preserve with metal compared to eccentric reaming? And this was a study done by Tom DeQuinn, one of my former fellows. And the bottom line is you can save over 50% glenoid bone. So you can see on the left how much bone you remove with reaming and how an augmented base plate allows you to preserve bone and the best quality bone. So again, 40 to 50% bone savings and preserving the best quality bone with less impingement. So a number of us now use an augmented base plate to create the tilt in all our reverses and then adjust the tension on the humeral side, as Professor O showed, with offset trays. So the benefits of metal, it's simple, reproducible, and time-efficient method to provide lateralization. So here's a technique, massive rotator cuff tear in this patient. What we can see, no arthritis. We ream the bottom part of the glenoid to 50%. And then what we'll do is we'll place the augmented base plate in there. We'll prepare it and place it in the same rotation. And then we'll be able to go ahead and fix it down. And you can see on the intraoperative view how we've created the tilt with the base plate. And then we'll dial the glenosphere down a minimal amount. I think we used to dial glenospheres down excessively. I've learned this lesson now. I only want the glenosphere just 2 to 3 millimeters below the bottom part of the glenoid. And here are some examples here. This is a very small woman, how we used an offset tray and an augmented base plate. As Professor O mentioned, it's interesting, the offset trays slightly medialize the humerus, so you get less impingement, plus also you can resect less humeral bone. This is an example of getting less impingement, as you can see. So a number of us, including myself, I use the augmented base plate on all my reverses. I've also gone to bigger glenospheres in many men, and I minimally dial the glenosphere down below the bottom part of the glenoid. And that offset tray, again, can help in terms of minimizing how much bone you have to resect. We can also talk perhaps, and I think Richard may have some comments on advanced polyethylene. So again, example of a small woman with an offset tray. And what I thought I would show now is a case of mine of a standard reverse arthroplasty of the shoulders. This is a patient with rotator cuff arthropathy. We can see here, we get a CT scan on all the patients to be able to plan the case. You can see this patient has some superior glenoid erosion. And what we'll do is we'll go ahead and plan the case. So we can see, we'll put this in there. This patient has 6 degrees of superior tilt. And what we'll do now is to try to understand where should we place the base plate and what type of base plate should we place. So this is a standard base plate, a mini base plate. You can see the amount of eccentric reaming we're going to do in the central and inferior part of the glenoid to be able to go ahead and get our contact. And then I think, as I've learned from, again, my good friend Tom DeQuinn through some of this research, what we'll do now is we'll start using augments to see if we can preserve more bone and preserve more lateralization rather than reaming away that bone. So what we'll do now is to go ahead and switch from the mini. We'll look at a small augment, and you can see now we get some improved lateralization. And then what we'll do in this patient, we'll use a medium augment, and this will be able to get improved contact and improved lateralization. The other thing we'll do is to think about the glenosphere position. Again, I'll minimally dial the glenosphere down in these patients. A hot topic in the US now also is quality of planning, ensuring that the plan we come up with is what we actually want. So this is an example of the intraoperative guide. And what we'll do now is with this guide, we'll have depth control. So I can preoperative plan exactly how much bone I want to remove and how deep. And there's going to be a guide we'll place on the reamer. This is all planned out ahead of time. Delta pectoral approach, typically about a 12 centimeter incision right on the front of the shoulder. I like to go all the way up to the clavicle, just lateral to the coracoid. And there's always a triangle of fat proximally. I learned this from my mentor, Bob Cofield. Go north to find the delta pectoral interval, 1 centimeter medial to the coracoid. We've learned we do not need to force in a tight stem. So we'll go ahead and make a generous entry hole. We'll place an ice pick in there to feel the center of the canal. And again, I'm not going to force in a tight stem. We've gone to shorter and shorter stems. I'm a simple person, hemi-total reverse, cut it in 30 degrees of retroversion, as you can see here. We'll finish off our cut. We'll put a broach in there, and I like to release the capsule off the posterior aspect of the humerus. On the glenoid side, I like to sit the patient straight up and down. Try this trick. It'll really help you with glenoid exposure. There's different glenoid retractors. I like to use a retractor that has a hole in it. On the left, that's that glenoid access retractor. The center is the fukuda, but the glenoid access retractor is my workhorse. So what we'll do now is we'll remove the labrum circumferentially, as you can see in this case. We'll place a Batman retractor in the front. We want to see the entire glenoid surface, and then we'll place the guide on there. So the first pin will be able to go ahead, and that's where we're going to place our implant. The second one is more superior, and that's going to assist me with depth control. So we know we're down there, and now we're going to ream the glenoid. We want to ream a minimal amount of the glenoid bone away. And then we've already planned this case to be able to use a medium augment. So we have a little bit of bleeding bone in there on the bottom. We've preserved that nice hard cortical bone. We use a circular augment so I can dial in any orientation that I want. I've already planned the orientation. This is another interesting step where we can go ahead and prepare it and place in the same rotation. Another paper has come out and shown that if you have 5 degrees of malrotation of an augment, you lose over 50% contact. So we want to make sure we prepare it and place it in the precise way. So we'll go ahead and place a guide on the bone. Once that guide is flush with the bone, we'll stop turning the screwdriver. We're flush like that. We'll put a black cap on there, and then we'll be able to go ahead and ream the glenoid. I love that bend home and above. I learned that during one of my traveling fellowships. That can really help give you a nice view of the superior part of the glenoid. You'll see we'll preserve that hard cortical bone on the upper part of the glenoid itself. And there's the augment. We'll go ahead and pound this in, and then we'll be able to go ahead and fix it down. You'll see the compression we get. Some of us like a center screw, and you'll see the compression you get with that compared to a post. And then for me, I just put in 4 locking screws peripherally around there. So again, a simple technique. Once you see the whole scapula moving together with the base plate, you know you have absolute fixation in this case. And then we'll fill these in with the locking screws. And I like in a bigger patient to go to a 40 glenosphere. This is a smaller patient, 36 glenosphere. We'll dial it a few millimeters below the bottom part of the glenoid. And then we'll adjust that retractor the way we would like to improve our access to get the glenosphere down. This is the offset trays, as Professor O showed. So this is a standard tray. You can see there how we have humerus above. The offset tray, this is a +3 offset. And then we'll go to a +6 offset, because usually the circle on the broach there is on the inferior part of the humerus when we do reverse arthroplasty, so we get better coverage. And how about intraoperative motion? So this is a standard tray. And what you'll see is when we reduce it, we'll raise the arm up in the air and you'll get some impingement. We get about 110 degrees of elevation that way. And then what we'll do is we'll switch to a +3 offset tray, and you'll see improved overhead elevation. I really like the study, again, Professor O did, looking at this issue and how offset trays can improve it. So we get improved overhead elevation now with a +3 offset tray. And then the one I most commonly use now is this +6 offset tray. And what you'll see is better overhead elevation, looser joints, so we're not putting these in too tight. I think this is really helpful, particularly in smaller patients, and it avoids you overstuffing the shoulder, which we really need to avoid. So we'll be able to go ahead and snap that together. I use a little short stem, as you can see there. A number of us have gone to using E1 poly on reverses because we think that wear is going to be the limiting factor in reverse arthroplasty in many of these patients. We'll tap that down. You'll see the circle on the broach is on the inferior part of the humerus, and that offset tray then covers the humerus the way we would want. And then there's the motion we're able to get with that patient. Nice rolling motion, a nice overhead motion for this patient. So that's just the typical reverse that we do now with the patient-specific instrument. And there's the post-op X-ray, the offset tray, and the augmented base plate. So I think for me in my practice now, I think recognition of the RSA angle is key to preserve glenoid bone. I will tell you, advanced preoperative imaging planning has really improved our ability to plan and execute it. But a hot topic also we might be able to discuss is that preoperative planning software is all or not the same. And I think accuracy of them is becoming a bigger and bigger issue. At first, we were just happy to have the planning software. Now we're realizing accuracy is critical. And I'd like to thank the meeting organizers so much for the opportunity to participate today. Thank you very much.
That's great. Inho, you're still on mute there, but that was terrific, John. As always, I always learn a lot from hearing you talk. So thank you very much for that. There's a couple of questions, but I might just jump straight into just asking about planning, which you finished off on. are there particular problems that you see with the planning software? Do you use it always? And as a flow on from that, do you always use the jigs now, the printed guides, or do you see there's some cases where there's some limitations to that? So it's a bit of a two-part question.
Yeah, it's interesting, Richard. So at first, people were happy to plan. So there's some systems out there that are auto segmentation only.
Yeah.
So you put in the CT scan, you get it back. But the problem they've recognized now, 50% of those plans are wrong because they're unable to separate the osteophytes on the humerus from the glenoid. There's one of our colleagues and friends who unfortunately has a video out there, and he's talking about planning a case. He continues to refer to the osteophyte on the glenoid, but it's actually an osteophyte from the humeral head. So there was a paper published in Journal of Shoulder and Elbow Surgery this year I'd encourage you to read that talks about the issue of auto segmentation alone. So for me, I think a number of them have gone to auto segmentation plus an engineer checking the quality of it with manual segmentation. So I think the combination of both now is important. You know, Richard, I think to be cognizant of cost issues, I think for me, I've gone to using it on more and more cases, but I think it's probably most beneficial to the really complex cases, glenoid dysplasia, cases such as that. So with limited resources available, I would use a guide for that. The planning software is free for most companies. I like to use more and more guides, but I think it's helpful for the complex cases. And again, Richard, I saw your data from the Australian registry. The preliminary data is interesting about how guides help.
Yeah, no, look, it is, and you know, we need like all data, you need follow up, and we're waiting for that before we do too much, do any sub analysis on it. Going back again, just as a background question, CT scanning, is that your routine now for all shoulder arthroplasty, shoulder replacement surgery?
You know, I think it's been enormously beneficial. I actually started the day I started practice 21 years ago, getting a CT scan in everyone. And I have gotten to the point now where I almost ignore the intraoperative appearance of the glenoid and I only trust the CT. I think we find that all of us have had that funny experience in the OR where some days the glenoid is facing like this towards you with the scapula. Some days it's like that, and some days it's like that based on the kyphosis of the patient. So I tend to trust the CT scan on one side and I have plain x-rays on the other, and that's what I use. So for me, it's become the standard. How about in Australia, Richard, for you and your practice and your colleagues?
Well, certainly I can speak to, again, we do have national data on this, and in total shoulder replacement surgery, 67% now of cases get advanced imaging. Now, interestingly, that is predominantly CT scanning in, you know, probably 80 or 90% of cases, but some of our colleagues are actually using MRI, and we know with, although it's not validated in the same way, but with MRI, you can get very good recognition of the bony landmarks, but not so good in the more complex deformed shoulder. So, but certainly CT scanning, and that I totally agree with you, that is my go-to for every case. But it's interesting, sometimes I like your comment about the plain x-rays, don't throw them out, because sometimes you want that global overview, and I like to have that sitting there aside. So it's not one or other for me, it's one and the other, both. That's just that's my practice experience. Sorry, Inho, did you have a follow-up question from before? Because we lost you a little bit early.
Thanks, Richard. We have a couple of questions from the audience. One is, John, do you have any concern on the bigger metal augment? I mean, the question is, if you use a large metal augmentation, would that matter in the long term in terms of loosening or stress shielding, something?
Yeah, and it's interesting. I was at a meeting in Brazil with Pascal, and we both came to the same conclusion from different sides. He used bio-RSA at an angle to be able to preserve glenoid bone. We came from the augment side, so we each came from different sides. We both realized that the key on the glenoid side is to preserve the bone and also to be able to go ahead and get some lateralization. I think what I've learned over time, if you're going to do that, which I like, that you don't want to then over lateralize. So I don't use +3 or +6 glenospheres. I never use those glenospheres on primary cases, and I dial the glenosphere down a minimal amount. So I don't try to overforce it on the glenoid side. And on the humeral side, I think having the offset trays allows me to cut less humeral bone. I think we've learned the lesson of our hip and knee colleagues. So they told us for years, you know, why are you using bone graft? A number of us have moved away from bone graft on the humeral side, haven't seen resorption. And I think the challenge now is on the glenoid side, I agree that bone graft is less expensive. Technically preparing it is more difficult. And what's concerning are the late failures we're seeing. And it's not just one surgeon. So when Brad Edwards has a problem, when Jerry Williams has a problem, when Sanchez Sotelo has a problem, when Sperling has a problem, when Steinman has a problem, it's not just one person that's having a problem with bone graft on glenoids. You're seeing it more and more surgeons now. So I think the tide is shifting away from bone graft in the shoulder. And I think our hip or knee colleagues are going to tell us, we told you this 10 years ago.
Thank you. One more question from Dr. Stuart Proper. If you are using a 44 millimeter glenosphere, do you place the base plate any higher than a smaller glenosphere? It's a technical question.
Yeah, it's a great technical question. So what I do is I use the base plate I use is 25, and in a small woman, I use a 36 glenosphere, and I use a 40 in many men. But it's such a good question, and I learned this one day because we have a lot of surgeons at the Mayo Clinic, as you know, that like to do total elbow arthroplasty. So one of my colleagues cemented the humerus in the total elbow all the way up the humeral shaft, right below the head, right? So he sent that to me for an arthroplasty and a little rheumatoid, and that was a tight shoulder. And what I realized that day was in a really tight shoulder, you can actually take the glenosphere, if it's eccentric, and dial it up and still have a few millimeters of metal below the bottom part of the glenoid. So actually in a really tight shoulder in a complex case, there's nothing wrong with doing that. We realize to prevent notching, all we need is a few millimeters of the glenosphere below the bottom part. But yes, I don't overforce that in terms of lateralization and thickness.
Okay, our panelist, Ashish, you have a question for John. Muted.
Hi, John.
Good morning. Good to see you.
Good to see you. Good morning. We've discussed this before as well, but expanding on our discussion, I know your work on the plus 3 mm offset has made things remarkably different, and we've been a big, we've endorsed that regularly. I would like to know, in which cases would you still use the standard metal tray, not the medialized one? And in which cases would you use a +6 offset medial tray?
Now, I tend to use in my patients, I use a lot of the +6 offset trays. I tend to use a number of them because I tend up front to make a pretty aggressive head cut. So actually, before I scrub in the OR in a small woman, before I scrub in, I say, open up a 36 glenosphere, dial it to be a +6 offset tray. You open up a small augment, I'm going to place it superiorly. So it's just the bread and butter for me. And I think in those cases, it can help because I can resect less bone. You bring up a great point, and I've actually been thinking more and more about this. The cases that I don't use an offset tray are the revisions that have a history of instability. Because what I worry about in those is I don't want medialization. I really want lateralization. So those are the only cases now I think about a standard tray. How about for you, Ashish? Love to hear about your experience and thoughts on this.
Yes, I agree. Pretty much same. Our Indian ladies, like the Koreans, are much smaller in size. So invariably, it's going to be a 36 glenosphere. I always put it to B so that we've just got enough eccentricity on the glenoid. And our go-to metal tray is +3. And if it's a very small lady, then I would use +6. I've just stopped using the standard tray because it doesn't fit into our, unless we have a large 6 foot, 120 kg hunk, then maybe yes.
Okay,
and
John.
I think your point too, Ashish, is that I don't force the base plate on the very bottom part of the glenoid anymore. We used to do that. So I'll put it 2-3 millimeters above it. The other benefit of doing that, of course, is it allows you to resect less humeral bone, and you won't have as much glenosphere below the bottom part. So I've done those things now as well. I know someone brought that up and I didn't answer. Thank you.
Thanks very much for your insight. Now, Dr. Yap, we have a
John, John, thank you very much for your talk. I have a question. If you have a case with a severe B2 glenoid, what is your policy? Do you still use your standard metal wedged implant, or you combine it with a bone graft, or do you ream more, or do you use a custom-made wedged implant? Have a posterior.
Yeah,
inferior wedge.
Another great question. So if the rotator cuff is intact in the US, what I do now, 10 degrees of retroversion or less, I asymmetrically ream. 11 to 24 degrees, I use an augmented anatomic component. And 25 or more, I go to reverse. And the system I use, there's lots of different systems out there on the reverse side, has 10, 20, and 30 degree augments. So it's rare that I need to use additional bone graft with it, but on occasion I do. The interesting thing too is that the cases where I get a custom glenoid made are not that common, just a few a year, but it's probably now in the patient sent to me with a failed reverse. So if someone has a failed reverse with massive glenoid bone loss, that's where I think about it. And from a cost perspective, those are really expensive. In the United States, they're very expensive. So I use those selectively. But for me, just knowing what we've experienced, that for me is preferable than taking someone's iliac crest or using bulk graft.
Okay, we have a, okay.
Can I just, yeah, sorry, you know, can I just follow up on that? Just going back to more a philosophical question, John, if I might, about what you aim to do on the glenoid side when there is bone loss. Are you aiming just to restore joint line, you know, to try and get back to the paleo joint line where you think that joint should have been, or are you trying to add lateralization on the glenoid side?
Yeah, I don't force a lot of lateralization, Richard. And I'll tell you the one thing that I've done, which is also controversial, I do like to get people back to neutral. I don't like to leave people in retroversion. I think you start chasing your tail. If I leave it retroverted, what do I do on the humeral side? I think the other thing I've learned, Richard, I think you brought up the CT scan question, which is a really good one. I think looking at the CT scans, that yes, there is some artifact on the revisions is critical, because sometimes we get focused on how am I going to get this cemented humeral component out? How am I going to deal with the glenoid? But the key for me on the glenoid is, how did that surgeon place the glenoid component? Is it retroverted? Is there bone there that I can key off of to get the glenoid back to neutral? And really understanding the CT and the revision setting for me has become more and more important.
Yeah, okay. Just sorry, another question that I was going to ask earlier, Sheesh, but and a couple of others, but it's come up now. Increasingly common, the second side, the patient and their second reverse. We're starting to, certainly in Australia, you know, this is becoming by far and away the most common total shoulder we're doing. We have a great love affair with reverse shoulders here. Do you treat that second side in terms of the version offset any differently? Do you try and, you know, do you try and customize? In other words, looking at their range, particularly internal rotation, I'm thinking of.
You know, it's interesting. I don't, and I will tell you that I'm still one of the advocates in the United States for whenever I can do an anatomic total shoulder, I will do it. So if I have an 80-year-old woman who's got minimal glenoid wear and a good cuff, I'm doing an anatomic, even if I did a reverse on her other side, which I know is controversial. And I'm sure we would all agree a reverse is faster and easier to do. But I really do still try to do anatomics whenever I can. You always have that pressure. I think we all feel it. If you do a reverse on one side and they love it, you almost feel an obligation to do the second reverse. But sometimes you have to resist the temptation. How about for you, Richard? Do you change the implant position?
I love. Thank you for taking that back to the anatomic or the conventional shoulder, because I strongly agree with that. Don't throw that baby out. The bathwater is still warm on that, I think. But I will try and dial it around the version if we have to go to a second reverse. But I'll look. But as with all things, take a history, examine the patient, and look at what their rotation and what their functional range is. And if they've got no functional deficit, don't play with it. But if they do, try and, it's often the bit of IR they're missing. And that I'll just tweak that a little bit. That's all.
So
I got a question.
One question from the audience here. John, do you think, this is very futuristic question, do you think there will be a role for navigation assisted technique in the future for reverse?
I think there's going to be a variety of different techniques out there to be able to improve our ability. I think it's still to be determined which one is going to be the most effective. I did get a good question from Professor O there about using E1 poly, and there's some data Quinth Rockmore has 9 times less wear, and there is increased cost. But I will tell you, if you ever have this problem, what I did at Mayo is I brought our head of material management in the OR with me one day on a 65-year-old woman. I cheated. Her life expectancy is almost 90 years old. And I stopped at that point. I turned to him and I said, well, if this is your mother, which poly do you want me to use right now? And he said E1, and then we switched over. So get them in the OR, it'll help.
Nice work. I like that.
All right. Thanks very much. It was such an exciting. Okay, Angus.
I'd like to come back to John. I mean, John, you're my hero. The way that you stood up for anatomical shoulder replacement cheered me up enormously. There seems to be an incredible drive in certain countries for people to use reverse the majority of the time. Anatomical, if you put it in correctly and you rehab them well, they do very well and they last longer, we think. We haven't actually got all the data yet, but there's some evidence that supports that. And I think that coming out publicly and explaining to this audience, the 350 of them, that the experts are still favoring anatomical where possible, you've done everybody a good favor. Thank you.
I would endorse that, Angus, provided, and our data shows you use cross-link poly, and it will it's lasting longer. It's in the anatomics.
Sure,
and
it's wisdom. Yeah. So it was such an exciting session. I do appreciate, John. I mean, it was excellent, your scope and perspective. I mean, sharing your experience, it was amazing and very, very instructive to us all. And now over to Angus.
Thank you very much. It is my real pleasure to introduce Jaap Willems. He calls himself Willem Jacob, but he's actually Jaap. And he is one of my long-time friends and colleagues. My best shoulder friend was Steve Copeland, who died 6 years ago, was a great technical surgeon. Jaap from the Netherlands has a tremendous reputation as being a very good, well-experienced shoulder surgeon, and we're delighted to have him join us. He is a leader of shoulder surgery in the Netherlands, has been the chief of orthopedics in the Ons Lief Vrouw Gasthuis, Amsterdam. Well, Jaap, did I get that anything like right?
That's correct. Nearly okay. Thank you. Thank you for a nice words.
We'll come back to you. The discussant is going to be Erica Colleen, and I'll talk about Erica a little bit later on. So over to you, Jaap. We'd love to hear about your experience of reverse shoulder. I'm delighted to listen to you.
Thank you very much. Angus, thank you very much, Ted, for joining me. I'm very happy to be again attending an APOA meeting. And I thank Inho and Nobu for inviting me to this talk. Actually, Inho and Nobu asked me to talk about failures, and luckily failures is not that infrequent. But what is a failure? Normally, when we talk about failures, it's about complications and revisions. But for me, a failure is when post-operatively the goal of a well-functioning shoulder without pain is not achieved. And luckily, most of them are treatable, but some of them are not. Like in this case, where after a fracture case, all the tuberosities were lost, there's a poor constant score and a painful shoulder. And there's hardly a solution for that problem. Well, we will talk about the complications and that caused the failure, most of the failures. Overall, the percentage is 15%. There's a wide range in the literature, but the mean is 15%, which is quite considerable. But what is a complication? Sumsein made a distinction between complications with worse clinical outcome or problems, no clinical consequences. But there is an overlap. Sometimes notching is not a problem at all, but sometimes it is a severe problem. So this distinction is not very absolute. These are the most common complications. And I agree with what Richard said, and also in my experience, instability is the most important complication. But the other three are component loosening, periprotective fractures, and infection. And there are more, but these are the most important, and I will address in the coming minutes these complications. Well, I think Mark Frankel in this group made a very nice distinction between several sorts of complications. You should be very careful examining your patients. What is the basic cause of the failure? Loss of compression, loss of containment, or impingement. History is extremely important. Is there a trauma? Did it happen without trauma? Physical examination, especially neurology, is important. Standard X-rays in 3 directions, including the full humerus APOA bilateral. And you should, and this is simple paperclip, you can do other devices, you need to have a proper impression what the length is compared to hopefully the normal other side. Otherwise, if you have no other contralateral normal shoulder, it is difficult to guess what the shortening or lengthening is. And the same for humeral medialization. You should measure and compare it with the normal shoulder, if there is a normal shoulder, which unluckily is not always the case. Well, the early post-op dislocation happens quite often, and we can discuss later what all the reasons are, but you can treat it with an open or closed induction with 6 weeks in immobilization. That has a reasonable chance of success, but consider a proper post-operative analysis. You should make a CT scan, measure the glenoid version of humeral version. You can use X-rays, but for the glenoid version, I find the CT scan, its suppression of metal, very helpful. A loss of compression, if you have undersized implants, I made a distinction between less or more than 50 millimeter. And of course, that's relative. 50 millimeter in an Asian patient is different from a Dutch patient, which is normally, which is actually belonging to the largest, the highest population in the world. So that is relative, but you should consider at least a measure. If there is less than 50 millimeter humeral shortening, you can use either a thicker liner, you can use a metallic spacer, you can use a constrained insert, which will decrease the range of motion, but at least making the shoulder more stable. You can use a larger glenosphere, which only helps some millimeters, and eccentric glenosphere as well. So these are the less important measures. Basically, you have to solve it at the humeral side. If there is less than 50 millimeter humeral medialization, then, and there's instability, you can use a larger glenosphere or a lateralizing offset glenosphere. And there's now, nearly all companies, there's a wide range of glenospheres available, centered, eccentric, and all sort of offset. If there is a considerable humeral shortening, you have to, most of the case, you have to revise the humerus. You place it higher and with a longer stem, mostly. Generally, I use bone graft, not only to compensate for the bone loss, but also increase the deltoid wrapping. And you can use an allograft prosthetic composite, which is quite expensive, but that's especially for cases like in tumor cases. The use of inferior base plate or accent base plate is not very helpful in this case of humeral shortening. It is too little to add to the humeral length, actually. More than 50 millimeter humeral medialization, you normally see the loss of deltoid contour compared to the normal shoulder. Well, most of the cases you have to revise the glenoid prosthesis. You can try with larger glenosphere and test the shoulder, but normally it is not that stable and you need a bone graft. And we can discuss with John if the bone graft will help or you need a metallic implant, but I standard use a bone graft to increase the distance to the central point. At the humeral side, you can change the direction. And some of the devices made it possible to change the position of the tray, putting it more medially and lateralize, and that way the humeral implant and also lateralize the shoulder. The deltoid insufficiency, it has been discussed earlier. A non-functioning deltoid is mainly seen after revision procedures or in excessive lengthening. Especially when the deltoid is non-functioning, the axillary nerve is involved, and in excessive lengthening, sometimes also the radial nerve, and sometimes plexus pathology, traction on the plexus plays a role in a non-functioning deltoid. Luckily, it is mostly neuropraxia and it recovers. But sometimes it is, especially in revision cases, the radial nerve is damaged. That is a serious problem. Well, we know from the, that the reverse in a compromised deltoid is a big challenge. There is now literature that if you have a partial insufficiency, 1/3, and it's mostly the anterior part after previous procedures, or the 2/3 when a transdeltoid approach is used for a fracture case, the middle and anterior part are defect. But luckily, the reverse is still functioning in these cases. There are poor results with global insufficiency, where the complete deltoid is gone. The clinical outcome is rather poor, although the instability is not always that present. Coming back, to the subscapularis insufficiency, there's an ongoing debate, and we discussed it earlier. Should you repair or should you not repair? There are several studies that makes no difference if you have a subscap or not, or you have, if in these series you have more instability. The problem with all these series is that there are a lot of confounders. Many of these cases, there were revision cases, and that makes it not comparable with primary cases. So that is a little bit debate going on, should you repair. But also containment. Oh, this is an example. It's right easy to solve. This is a more difficult to solve. You have to revise the humeral component. This is an old Graham prosthesis, and luckily the present prosthesis, especially the shorter stems, doesn't lead to this problem. But this association of the prosthesis components can play a role in instability. Another cause of containment, if you have severe notching, severe polyethylene wear. This was a case where there was severe notching, no instability due to the glenoid prosthesis, but instability due to the insert. You can replace the insert quite easily. And we all know that in especially the Grammon type of prosthesis, there is a severe wear of polyethylene wear. And this computer model of Terrier showed a considerable wear compared to a total shoulder prosthesis. The third cause of instability, impingement. An ectopic bone, especially in post-fracture cases, that malunited or ectopic bone or a malunited greater tuberosity, like shown here. And malalignment of the prosthesis, too much retro or anteversion of the glenoid, giving anterior or posterior impingement, which can lead to instability. And another quite important cause of impingement is the soft tissue, capsule or tendon that remained in the shoulder and causing impingement, and the triceps origin. Triceps origin can sometimes be very, very well developed and causing inferior impingement. And you should not only test anterior and posterior instability during the surgery, but also the inferior instability. Sometimes you have to cut away the triceps. And of course, you have to consider osteophytes inferiorly. Well, the fourth, of course, the most frequent, the scapular notching, 0, 1, and 2 hardly ever cause instability, but type 3 and type 4 can lead to severe notching, like here, breakage of the screw, impending instability. And that is another case where there is a dislocation due to breakout, due to this very, very severe notching inferiorly. That is an older Graham type where we didn't pay attention that much on the inferior or eccentric placement. So generally, you have to revise the glenoid with a bone graft or a base plate, and a base plate with a longer peg. But presently, there is a lower incidence of notching thanks to the lower neck shaft angle, the lateralization, and the inferior or eccentric glenosphere. And there is an interesting review overlooking more than 2,000 shoulders. Two parameters were compared, the neck shaft angle and the notching. And there's more severe notching, as you can expect, in 155 degrees. But interestingly, they didn't see difference in number of the degree of the dislocations. The third pathology, periprotective fracture on the humeral side. I like this classification of Kirchhoff and the three areas where the fractures occur. Well, in a stable fracture, you can use conservative treatment. This patient refused treatment and healed well with malunion. Normally, I use OREF, either cyclage of plate and cyclage. In unstable loop replaces, you have to revise, and here an example of a revision and the long-term and the 1 year follow-up with a good result. The glenoid fracture always have to be revised 1 or 2 stages. An example, 65 years old, kidney insufficiency and knee arthrodesis after an infection total knee, and hemi for AVN of his humeral head, severe wear, put in a reverse with a bone graft, 16 months later fall, part of the bone graft was resorbed. I didn't dare to put in a 1-stage revision, so I put in this graft and put in hemi and maybe later on a reverse, but he was reasonably happy with this function, and the prosthesis survived the patient. He died 3 years due to his comorbidities. So hemi can be a solution. The acromion spine fractures, not that very frequent. Osteoporosis, the main reason. It is more seen in inflammatory arthropathy and massive cuff tears, the misplaced grooves going into the spine. Well, these are the position problems, excessive lowering of the humerus, and 2 medial glenoid given severe vertical pull of the deltoid, and 2 lateral glenoid can give stress on the acromion. So there are several reasons, but luckily not that frequent. And now we use the Levy classification in 1 type of 3, here in the spine and here in the acromion. There's an ongoing debate on the treatment. Generally start with conservative treatment. In painful non-union, go for surgery, and actually I operated only on painful non-unions of type 2 and type 3. And clinical results are generally inferior, both after union or after non-union. The last group, prosthetic joint infections. These are the standard diagnostics. ESR and CRP are not very reliable. Synovial interleukin-6 is getting more reliable. Biopsy, not very reliable, both through aspiration or arthroscopy. You need X-rays at least, and a CT scan, and sometimes nuclear scintigraphy. And these are the organisms most frequently seen in shoulder reverse infections. And keep in mind, pain at rest is an infection until otherwise proven. And since this meeting we had in 2018, the meeting consensus on musculoskeletal infection, we have these definitions. A definite PGI is a sinus tract communicating with prosthesis, gross interarticular pus, 2 positive cultures with identical virulent organisms. And probable PGI, the 6 positive minor factors, and you can find this and this very interesting information on this website, probable and positive organisms. A possible PGI, 6 of these factors and no organisms. In acute prosthetic joint infection, you can mainly come out with an DAI, or debridement antibiotics implant retention. In chronic cases, you have to do a revision, 1 or 2 or even 3-stage revision. And in morbid patients who can't have surgery, you can consider suppressive antibiotic treatment, but it is not effective at the long run. So it is just a palliative treatment, actually. Well, we know now also from these data we collected in the consensus meeting that the 1-stage revision shows a significant lower infection rate and a significantly lower complication rate versus 2-stage. Although we have no comparative studies at the present in the literature. If you do 2-stage, I prefer to use a spacer between the surgeries. Revision of the stem is not always that easy. Here, I was very lucky to extract it together with the cement mantle, but generally it is more difficult. These are my standard approach: preventive wires around the shaft, longitudinal osteotomy, and cement you can use, remove with the chisels or ultrasound, but you have to be very careful. I once damaged the radial nerve. The bone, the ultrasound is based on the fact that you hear a different sound between bone or cement, but in the arthroplasty shoulder, the cortex is rather sometimes very thin, and you can't hear the distinction between the sound of the cortex of the cement. So be very careful in this using the ultrasound. 2 cases to end up. A male 75 years old, 4 previous surgeries, including hemiprosthesis. He was referred because of the painful hemiarthroplasty. He was revised to reverse, and all the perioperative cultures were negative. So this is the situation after the insertion of prosthesis. 8 months postoperatively, already impending loose lines, and here a complete loose prosthesis. He had a positive culture, and here we put in a spacer, And he hated the spacer. It was too painful. So we ended up with a flail shoulder, and this was his function. And he was reasonably happy with this situation, at least no impending surgery anymore, and the pain was bearable. So a flail shoulder can be an option. Sorry. Case 2, a 45-year-old lady, post-instability, osteoarthritis in the left shoulder. We inserted a total shoulder in 2003. And this was her X-ray and her CT scan. The perioperative cultures were negative. 1 year post-operatively, mild painful, limited function, and a constant score of 58. And here, a loosening of the glenoid already after 1 year. We did the revision of the glenoid, microscopically not infected, 5 cultures were negative, and we did a gram stain during the surgery, and we dared, because it didn't look infected, to put in a new glenoid prosthesis, as shown here. 2 years later, there was a recurrence of pain. There were lucencies around the glenoid and the humeral component. We removed the total shoulder, and 3 out of 5 cultures were now positive for CNS. We did a 2-stage revision, a spacer, 8 weeks later, the reverse. Cultures were negative, and 6 weeks intravenous antibiotics, another 6 weeks oral antibiotics. Did well for 1.5 years. The recurrence of pain, the aspiration showed the same CNS. We did a 1-stage revision of both components. She did well for 1 year. Recurrence of pain and loosening of the stems. We removed all the components. And we sent her to another center for a second opinion while we considered an arthrodesis, which was quite a heavy decision. Yes, we are nearly ready. So we did an arthrodesis with a vascularized fibula graft. It took 2 more operations to get it completely healed, but finally she was reasonably happy. The arm was a little bit shorter. It makes it a little bit more convenient for reaching her hand to the mouth. So that was an end solution, but for that patient, that was the best solution at that moment. We have very few literature on revision of reverse arthroplasties. This 2-center study from France, 80 shoulders. Instability was the most prominent cause. Glenoid failure in 24%, infection 24%, humeral implant losing 10%. So basically instability is the number 1. So complications are not rare. Most of them can be treated, luckily, and some end up with a flail shoulder or a spacer or in very severe cases, an arthrodesis. Thank you for your attention.
Thank you, yeah. Lovely. Now, I'd like to go from an old star, with due respect, yeah, to a rising star who is the discussant at this meeting. A lot of you will not know Erika Collin. I have had the honor of meeting her in Korea, and I can tell you she blew me away. Nothing to do with her appearance, but with her knowledge and her scientific background. She is going to be one of the leading upper limb academic surgeons in the world. And she's now going to challenge you, Jaap, with questions related to your presentation. Erika.
Thank you, Professor Angus, for a wonderful and most delightful introduction for me. Dr. Williams, your talk is magnificent, but I have a few comments on your talk, which perhaps related to my background as the 3rd generation of the shoulder surgeon, maybe. I would like to make a comment on the PJI, the prosthetic joint infection. So case number 1, that guy has a flail shoulder at the end. And why you didn't do arthrodesis for the case number 1? Can I know the reason?
The main reason that he had totally 6 shoulder surgery before, and he was really fed up with any other surgery. So I suggested him after removing the spacer to put in the reverse, but he refused. And that is sometimes the case in these failures, that patients had so many surgeries before. It starts with a fracture treatment, a redo for fracture treatment, and then it failed to remove the plate and do an adhesiolysis. And then the fourth is a reverse, and the reverse gets infected, and so on and so on and so on. So that is the cases I sometimes see, and they really are fed up with it.
Okay, so
Erica, if I could come in here, doing an arthrodesis in a case like this is really, really difficult because there is very little bone left to arthrodesis. And therefore, one alternative is to get a mold of the proximal humerus made and put that in as an interposition. But it's a really difficult situation. Back to you, Erica.
So a resection arthroplasty sometimes is a solution for for a severe shoulder joint problems. What do you think, Dr. Willems?
Yes. Well, I always offer the patient again a reverse, but sometimes a failed shoulder is acceptable, but generally the clinical outcome is poor, but the pain is depending, sometimes substantial, sometimes reasonable. So sometimes patients end up with a flail and they are happy, and sometimes they come back and say, please, can you do something? And then you can try another reverse arthroplasty.
Okay, I'm asking this because a prosthesis is very expensive in our country. So we do have a money problem too. A second question is a follow-up question for the case number 2, which is very related to case number 1. In the case number 2, that was a lady that really catch my eyes, that I only saw a few arthrodesis case. And that case, she had a multiple attempt of debridement and component revision. But the ending is arthrodesis, and patient was, I think, happy. I begin to think that perhaps arthrodesis is not as bad as I think and could be a feasible option for a complicated PGI, because I think I heard that an arthrodesis of the shoulder is actually a historical solution for the severe shoulder joint problems. Maybe it's not very historical. No. What do you think on this?
Yeah, well, I think in a certain aspect it is historical. When we didn't have a well-developed shoulder arthroplasty, shoulder arthrodesis was a very common procedure. But I think the only indication nowadays for a shoulder arthrodesis is neurological problem. And there's a complete flaccid shoulder due to involvement of all muscles around the shoulder. The shoulder arthrodesis is the best solution. And well, luckily, I had only 2 cases of shoulder arthrodesis after the failed reverse. But indeed, as Angus said, it is a difficult procedure. After that, after my cases of arthrodesis, I had to do 2 redo operation to add more bone to get finally healing of the defect.
Erica, can I interrupt you for a minute?
Sure, Professor.
I think Yap gave us a very good insight on prosthetic joint infection, but I would like to hear how John Sperling and Richard Page, they deal with this prosthetic infection. Any of you attempt single-stage revision surgery, or do you prefer staged revision as always?
Yes, for me, for an acute infection in a well-functioning prosthesis, I'll consider a poly exchange and a debridement. Unfortunately, most of the people that are sent to me are chronic infections, and then I tend to do 2 stages. I'd love to hear what Richard has to say and what the registry tells us.
So first of all, yes, an acute infection, but you want a favorable host and a favorable organism. So I would throw those caveats in. So in other words, a patient who it's acute, you can do a poly exchange. You've got first of all, you've got an organism isolated. And secondly, you've got a host who can stand up with the antibiotics and has got not too comorbid. Otherwise, I still err on the side of 2-stage. And often that first stage, you're actually waiting for extended cultures to get some of the difficult organisms we have to deal with around the shoulder, particularly C. acnes, but there's a whole range of other things that can be difficult to culture, particularly when there's been multiple surgeries, there's been intermittent antibiotics, etc. So I think following the Oxford protocol, which was, I think Jaap alluded to, which is in that PJI link, is very important to, and the sensitivity and specificity is very specifically 5 samples for that. Taking more is actually decreases your the accuracy and the specificity of your cultures. In relation to the registry, John, what I can tell you is the results and the revision rate for revision for infection is over 30% and up to over 50%. So if you revise somebody for infection, the outcome is not good, but that's based on broad registry data.
So what about your experience in India, Ashish?
You need to unmute. Ash, unmute, please.
I agree with Richard. The revision of a infected prosthesis single stage is very likely for failure. Succeeded in 2 out of 10 patients, but it can come back anytime. It could be 3 or 5 years later. So a 2-stage revision is preferred. The difference between 1 and 2 stage is the functional outcome after a 1-stage revision is far superior than the functional outcome after a 2-stage procedure. But the result of control over the infection is far better in a 2-stage. So it depends on how fulminant the organism is. What intrigues me is that we don't see any infection from PJI as commonly as seen in the West. Most of our infections are Staphylococcus, if at all, and they're iatrogenic or coming from previous surgery. So K-wire fixations, previous surgery are more likely to get infected than primary reverse shoulder replacements.
And Professor, would you like to share your perspective?
Yeah, as John said, that in case of the acute infection, within 1 week of the symptom developed, I like to use the 1-stage polychange and massive debridement. But other than those kind of cases, I like to use, probably I do only 2-stage revisions. Usually it takes 3 to 6 months. I believe that laboratory exam and clinical symptom is much important than MRI. Usually MRI is really sensitive, so it looks still remaining bone infection or a fluid there, but it's just reactive fluid or reactive change. So I don't believe the MRI, but believe the lab as well as the patient symptom. It takes 3 to 6 months after first surgery. That's my.
So Angus,
Richard, can I ask Richard? Oh, sorry. Can I ask Richard Page? You referred, Richard, to a favorable organism. Can you define favorable organisms and separate them from unfavorable?
Yeah. So favorable organisms are ones where there is not a broad resistance group, and and I guess that's a segue into the fact that this is a multidisciplinary disease. So involving our ID physicians is crucial in this. And secondly, that there is an oral step 2 equivalent sensitive antibiotic that you can actually take the treatment from an intravenous to an oral treatment tablet. Yeah, and it has to be treatment that is tolerated by the patient. So increasingly the resistant organisms, some of the antibiotics are still active, but the patients can't take them. So this is where you need the ID team.
Jaap, you've been frozen out by the discussions going on, and it's only fair that we give you an opportunity to come back. Have you anything to say in relation to the discussion that's gone on, Jaap?
Yeah, well, basically my philosophy is that in cases where there is a clear infection, as shown by aspiration or even radiography, I tend to do it 1 stage. But in cases when there have been infected hemis before, and I did in reverse after proper culturing, and my reverse is infected. So the more complicated cases, I tend to do it in the 2 stages. So that it's, but it is not very scientifically, but mainly on based on my experience. What will I expect? But yeah.
Sorry, can I ask you specifically in relation to acute infections, how much experience have you of using DARE, and was it successful?
Well, infection is very early, and the most case I've seen is when there, by coincidence, is a severe hematoma after the primary procedure, getting infected. They do very well with DARE.
Yeah.
As soon as you see a component loosening, lucency lines, you know there is a bacterial intrusion into the humeral shaft. And that is a severe problem, which will never be helped with the DARE. So the DARE is for an acute infection, with even with a connection to the skin, and there is a sinus tract, but no loosening, then I consider a DARE.
And we've got 340 people attending at the moment. We need to guide them. And one of the things that I made a big mistake on in my early career is I did not intervene early enough in some of my cases, because you have to be convinced that you need to do something. What are the indicators, Jaap, in your opinion, for going in early and washing out and possibly exchanging components?
Oh, I think that makes definitely sense. If you have a suspicion of an infection, which is not shown by whatever investigation, there's nothing wrong with going in and doing extensive rinsing of the cleaning of the and exchange components. I normally exchange my liner. I remove my glenosphere. I rinse very thoroughly both. I put in some gentamicin sponge between my base plate and my glenosphere. And I try, well, it is more difficult to do it between the liner and the humeral stem, but we are being very aggressive. That might be overdoing sometimes, but at least not under treatment, these cases.
Thank you. And Erica, you have the last speech.
Thank you, sir. I have one very interesting question. Perhaps you might want to jump in as well. So during my fellowship with Professor John, he never let us touch the glenoid, the deltoid. The deltoid he will do by himself in every open rotator cuff repair. That is how he appreciates the deltoid. So my question is, if you have an unstable RSA, Dr. Willems, with a patient with a deficient deltoid, what do you do? Do you still proceed, or do you do another augmentation or reconstruction? These are the same question from Turkey, Professor Karim Bilsel.
You mean that when the deltoid is detached? Do you understand well, or?
Yeah, it could be very thin.
Yeah.
It could be detached, unfortunately.
Yeah. Yeah, well, if it has been detached previously, especially the anterior part in the deltopectoral approach, it is very difficult to reconstruct it. Sometimes you need some extra tissue. Sometimes I use an allograft fascia to making it a little bit more robust, and then fix it to the acromion and clavicle. And definitely immobilize for at least 8 weeks to get it better healed. And even sometimes I used an abduction brace to get a release of the deltoid to get it healed. It is a very challenging problem. The same with the transdeltoid. If you do an improper deltoid, transdeltoid approach, and you have a detached anterior part of the deltoid, you have the same problem. To reattach it properly to the acromion is a challenge. So
Ladies and gentlemen, I'm going to wind up now because this is the time has run out for my section. I'm going to hand back now to Inho John and Ted Ma to conclude the meeting.
Thank you very much all panelists, and it was an exciting meeting, and I can't believe we spent 2 hours for this webinar. And our president, Professor Ted Ma, will make a last closing comment.
Thank you so much, everyone. It's been an exciting webinar and a great discussion and interaction. Thank you all. I learned quite a fair numbers of tricks, and I hope you all too. I'd like to thank all the speakers, commentators, moderators, and especially you, the audience, for participating. And I thank Stryker for being sponsor. I'd like to thank Auto TV and Hand Up a Limb committee members and APOA Secretariat for the logistics and support for making this webinar possible. If you're not a member of this society, I really like to welcome you to join us as members. Please send your inquiry to us using the same email address or APOA online. In a few days' time, we will send you a quick survey for you to complete and return to us. Upon receiving the completed survey, we'll forward the certificate of attendance to you. Finally, I'd like to introduce Professor Kim Boon Sang, Education Chair, to brief us about the next webinar to be held on the 31st of July this year, which is also the APOA Annual Congress. Boon Sang, would you like to introduce the next webinar? Or Margaret Fogg, if you're there, Margaret.
Okay, Ted, can I introduce our next webinar?
Go ahead, Inho.
Okay, our next webinar is also a 3 sessions shoulder for SCR, which is a really hot topic these days, and elbow for osteochondritis dissecans, a common sports medicine issue. And we have an excellent guest speaker from Australia, Professor Gregory Bain. He's going to talk about Quebec disease. So you will have all the details and the information in our webpage.
Thanks for that. And to that end, this is the post-op webinar survey that we'll send you, but you can also log on yourself. Thanks again, everyone, for attending, and I say goodnight to you now. Bye now for all.
Thank you. Thank
Bye-bye.
you all.
Thank you.
Thank you. Thank you very much.
Thanks all.
Good day.
Thank you.
Thank you. Thank you.
Thank you very much.
Thanks a lot.
Thank you. Thank you very much.
Bye-bye.